Very much, Shaikat. And you were quite correct, and thank you for your introduction. And yes, you were quite correct that, obviously, when you are exposed to something and you can see the benefits of it, when you are training, then you are more than likely to pick it up. Of course, that does not mean that if you've not been exposed to it during your training, that as a glaucoma specialist, as a standalone or an institutional glaucoma specialist, or even cataract specialist, that you would not pick it up. So my focus really will be choosing the right patient for iStent, Inject, W, which whatever you may call it. Right now, W is what is being marketed. There are still a few generation 1 and generation 2 still lying around. And these are my disclosures. So I just put it in context. Minimally invasive procedures are not just desirable in glaucoma. They're actually, all pervasive in all specialties in medicine, and especially surgical disciplines, of course, because of its faster operating time, very high safety profile, rapid recovery with improved quality of life. Now, you think if a cardiologist says 2 stents versus CABG, what would you choose? I think anyone would choose stent rather than open heart surgery. Therefore, cost notwithstanding, patients prefer minimally invasive procedures. Open surgery is still a fallback, and in our case, it would be trabeculectomy, especially in advanced cases. So really, why should glaucoma be deprived of its innovations? So it is fitting all of these criterion, the trabecular micro bypass. The reason it's called trabecular micro bypass is because it's one of the smallest devices known to mankind that bypasses the trabecular meshwork in a very micro fashion, very, very small. In any case, let us go through certain facts about MIGS. They tend to open up dormant collector channels, especially in the inferior, inferonasal area. And, sorry. But this is limited by episcleral venous pressure, and therefore the importance of episcleral venous pressure cannot be undermined. Basically, there is a gradient of flow out of the eye based on the episcleral venous pressure. So the amount of reduction in IOP that you will achieve will and cannot be more than the episcleral venous pressure. Therefore, hypotony is not common in trabecular micro bypass. And let's limit ourselves to iStent here. Very low IOP cannot be achieved because of this. And that is why it is effective only in early disease, where these channels are still open. Trabecular meshwork is still not completely damaged. The trabecular channels, the micropores, and most of it is still intact. As a result of which, when you try and bypass it with a microstent, then the dormant collector channels tend to open up. And when the dormant collector channels open up, they then start a natural physiological outflow that helps to control the eye pressure. And that is why you want to choose early glaucoma or mild to moderate disease. You can even go for ocular hypertensives who are undergoing cataract surgery and they are on 4 drugs. Why to leave a patient on 4 drugs? The next point is an open angle is mandatory for any angle-based surgery. And this, of course, is the epitome of angle-based surgery. It is overwhelmingly safe when you compare it to traditional bleb-forming surgery. The commonest complication is an IOP spike. Okay, and can happen because of viscoelastic. If it is slightly delayed, it can happen because of steroid response as well. And steroid response is pretty common. Remember, the rest of the trabecular meshwork is very much in play in angle-based surgery. So this is common. And a transient hyphema, I have never seen a level. It could be suspended RBCs or maybe a little bit of a clot in the angle, but I've never seen a hyphema. But this can also raise pressure, and overimplantation is something that you need to guard against. And blockage can happen later, mostly either with pigment or sometimes with a synecdoche. So this is really the sum total of complications that most publications talk about. So let's look at a very nice study conducted by Alex Wang et al., where on the left there, you just saw a video, a fluorescein angiographic video, where of aqueous angiography, let's be very clear about that, where prior to implantation of the iStents, you can see that only about 1 or 1.5 channel is open infranasally. This is the nasal aspect. And once the implants are placed in position, sorry, that's still the first one. And the red arrows are pointing to the placement, you can see how the dormant channels have opened up and aqueous now flows out of the eye. Not just this, there's another very elegant study by Gilman et al., who's looked at outflow 1 year after implanting iStent Inject. They did 5 OCT scans in each eye. 2, 1 each over a section directly over the iStent Inject, then 2 more 500 microns away from each iStent Inject, and 1 at the opposite temporal limbus. And what did they find? They found 12 months postoperatively that there was a 75% increase in the diameter of the Schlemm's canal next to the iStent Inject. There was a 46% at the opposite limbus, and this was actually compared to normals. So that is how you can say that there was a 75% or a 46% increase. So dilation of the Schlemm's canal helps in physiologic outflow from the from the trabecular meshwork. So iStent basically are these, as I said, smallest known devices known to humankind. They are surgical grade non-ferromagnetic titanium. So if your patient ever asks you whether they can go through an MRI, it's not an issue at all. The first generation looked like this. It had a snorkel. It was L-shaped, and it was a half open pipe as well. The long shaft was put within the Schlemm's canal, and the snorkel had its mouth opened in the AC. The second generation was the iStent Inject, where 2 of them came preloaded. Again, this is much smaller than the iStent generation 1. This is about 1/3 of a millimeter only, 0.3 millimeter. And the latest innovation, which we are all using, well, it's not the latest, the Infinite is the latest, but the Infinite is just 3 iStent Inject Ws in one injector, whereas the W has a much wider base. So over implantation, one of the complications, as you may put it, is minimized. That base is slightly more than 300 microns, which is, much more stable. So whereas generation 1 was implanted parallel to the trabecular meshwork, iStent Inject W, Inject and W, the generation 2 and W are implanted, as you all have probably either seen it or done it, is parallel to the trabecular meshwork after making a dimple. So I just wanted to share, because I don't think you will be seeing these very much anymore. There's still a few in circulation, and I quite like it actually, because not only do I limit the price for the patient, but also it works very well. Initially, I had done quite a few of these. So you just go parallel, about 15 degrees actually. You slide it into the Schlemm's canal after piercing the trabecular meshwork, and you release, and a little bit of regurgitation from the angle, from the Schlemm's canal, sorry, and you know that you are right in position. And of course, you can always use viscoelastic to clear that area and have a better view. The iStent Inject, unfortunately, I have not edited those videos and I've been traveling, so didn't feel inclined towards it. But you dimple and you inject, as you just saw that. And Sushma will, of course, take us through all these videos, and we'll also talk about all the types of difficulties that you may face. Difficulty was faced here. It was slightly under-implanted, so it was tapped into position. So really, the essence of my talk is this: the ideal candidate for mix. And once you have gained experience, you can definitely deviate. But before you gain that experience, in the first few cases, I would really be very grateful if you could stick to these indications before you deviate. The reason being that if you start doing it in advanced glaucoma, you start doing it in refractory glaucomas, then what happens is that you don't get such a good response. And we know you will not get a good response. What happens then is that you say that the device is useless and the device does not work, which is not fair. Okay? So we've talked about this mild to moderate glaucoma on visual field criterion. Angle has to be opened. IOP controlled on 2 to 4 anti-glaucoma medication, and when they are undergoing surgery. Now, this is when you're combining it with cataract surgery. You can do it standalone as well, although it's not approved for it. It's uncontrolled, up to 30 millimeter mercury on anti-glaucoma medication. And this is where it really kicks in for me, where there are so many patients who are unable to take anti-glaucoma medications, intolerant to them, come back to you with significant red, watery, teary eyes and complaining all the time, significant ocular surface disease, and those that are allergic to anti-glaucoma medication or even preservatives. I should have added that. So let's take each one of them one by one. Patients with mild to moderate glaucoma on visual field criterion. These patients still have a functioning distal collector system, so the TMB is an efficient way to open up these dormant channels. I hope with the slides preceding this, I've been able to, convince you of that, right? Also, why mild to moderate glaucoma? Because we know that we are not going to achieve a very low target IOP. It is very much dependent on the episcleral venous pressure. So, in mild to moderate glaucoma, we don't have a very low target IOP. And so, therefore, these devices are very useful in such cases. What about visual fields? Yes, we should be sticking to an MD not more than minus 12 decibels. And we're talking about Humphrey visual fields. We're talking about Anderson's criterion. Of course, Anderson's criterion is a little bit more complex than that. They have talked about paracentral points. So we've simplified it a little bit. You can use a simplified version, but you have to be a little bit, what can I say, commonsensical about it as well. If the patient's overwhelming visual field defect is central, paracentral, points are involved, they can still fall under minus 12 decibels. Whether you're going to use it in those patients, what is your target IOP is you need to question yourself. It's a very good read, the reference that I've given to you in the bottom. Okay. Now, angle in angle-based MIGS. I know of practitioners who do not do gonioscopy at all. And just based on a deep AC, call it open angle. Angle has to be open. After laser peripheral iridotomy is also acceptable. But how do you know the angle is open? How do you even schedule a patient for angle-based surgery if you've not seen it in OPD? So practice should start in your clinics with an indentation type lens. I do not subscribe to those 1, 2, or 3 mirrors at all. They are not indentation types. They actually do not give you much information. I give you examples of all of them. And you have to familiarize yourself with a wide variety of appearance of open angle. It's not same in everyone. If you don't see it prior, you don't know when you're doing a direct gonioscopy what you are seeing. So you need to see. So you can see a very nice, faintly pigmented trabecular meshwork, posterior trabecular meshwork here. Here, again, it's not too bad, but you can see that there are far more iris processes there. The iris processes as well as the trabecular meshwork seems to be blending into each other in this particular angle, and in this one it is completely covering it. So these are all open angles, but they all have different appearances. Remember that iris processes are very fine filaments. They don't have this broad base that you see there in that picture now. Now, this is an open angle post PI. It has got a very small goniocyte. It's not even a pass. So in this, you can contemplate doing angle-based surgery. It should not be an issue at all. But look at these pictures. You see a pigmented line and you don't have indentation type gonioscopy. You think that is posterior trabecular meshwork. You're wrong. Look at the pigment here and the pigment here. It's the same, but that's in the Schwalb's line. This is your posterior trabecular meshwork. Of course, this angle is open. If you're doing cataract surgery with it, it will open up. But if you weren't doing cataract surgery and you thought this was posterior trabecular meshwork, you would be so incorrect. Yet another example. Wow, this one looks as though it really is posterior trabecular meshwork. But you indent it and you see how clearly your posterior trabecular meshwork and scleral spur becomes visible. You have to be able to distinguish between iris processes and goniosynechi. I showed you this angle before. These are iris processes, and goniosynechi or PAS do have this broad base if they are individual synechi, but you can always have a peripheral anterior synechi, which is completely covering the trabecular meshwork or is at the posterior trabecular meshwork. So there are different varying appearances of the angle, and if you don't pay attention to it in the OPD, you may fall into trouble in the OR. One of the sure shot ways I teach is by making, if you're not sure you're seeing Schwalb's line or posterior trabecular meshwork, is to make the corneal wedge. So you go off axis, you make it really thin beam, you look at high magnification, you see the two beams meeting at the Schwalb's line. Then any pigmented line beyond it is your posterior trabecular meshwork. Just have a look at how it would appear in a closed angle. It would appear as though the two beams are separated and that they are meeting somewhere much further down where the iris is covering that view. So these are the ways I would suggest that you familiarize yourself and be prepared, be ready for angle surgery. So what's the incidence of ocular surface disease in glaucoma patients on medication? Well, it's over 50%. And there are many, many publications based on this. Of course, you have preservatives in anti-glaucoma medication, aging, hormone imbalance, systemic environmental conditions, all contributing. But we cannot ignore the fact that alone, the molecule alone, or in combination with all these factors, gives rise to ocular surface disease. So it really is, no rocket science here. Which eye is receiving the anti-glaucoma medication? You can see the difference in the color, and of course, you can see the hypertrichosis as well. Same here. Now, this patient has had his left eye surgery done. He's waiting for his right eye. You can see that eye is redder compared to the other eye. And sorry, that was the same eye that came up later. Red, watery, tearful eyes, on medication is, something that we tend to ignore till the patient actually starts complaining too much. One thing I do is I do not start lubricants along with anti-glaucoma medication. What happens then is the patient does not understand that the anti-glaucoma medication is important, and because their eyes feel comfortable on the lubricants, they continue the lubricants, they do not do the anti-glaucoma medications anymore. So you give it a lag, a month, 6 weeks, or, you start when the patient is symptomatic, but don't do it at the same time. Then allergies, we're all very aware of the alpha adrenergic allergy that we see. It just doesn't happen immediately. Most of the times it's 8 to 9 months after commencement. It can also occur quite severe in carbonic anhydrase inhibitors. And please remember, in these cases, itching is the predominant symptom. So here, this patient, you would think that he has ectropion, but he has ectropion associated or caused by carbonic anhydrase inhibitor. Unbelievable. When it was taken away, sorry, 1 second. So when the drug was stopped, you can see how it was improving. And 6 weeks after, it completely resolved. So this was carbonic anhydrase inhibitor causing it. This, I think everyone can diagnose as frank allergy, but this again is carbonic anhydrase inhibitor. And so is this one. We talk about, I don't know why I'm getting a lag. Yeah. This is probably one of the worst I have seen, and this is an alpha adrenergic. You can see the lid, the skin, the eye, all extremely inflamed with allergic conjunctivitis, dermatitis. And once the drug was withdrawn, you can see such a dramatic improvement in the scenario. And we're all very well aware of the side effects of anti-glaucoma medication. Some are more systemic, some are more local, but we should all remember the preventive measures, and I don't think I need to go through that once again with you guys. So here you see in a 60-year-old, maybe orbitopathy caused by PG analog is acceptable, but I don't think it is acceptable in this young 23-year-old business school graduate. Something wrong with me. Let me, hello?
Yeah, I think there is a lag at your end.
Yeah,
That's
yeah, okay. Can you see it now? Yeah, this
yeah.
is the young 23-year-old. You can see what havoc prostaglandin analog has wreaked on her. And this is a young JOAG as well. Right side, I've done his surgery, so I'm able to pull his lid a little bit, but left side, which is on the day of surgery, you can see I cannot pull his lid down very much. These are cicatricial changes that take place as a result of prostaglandin analogs. Again, I'm facing the same problem. Let me do something. Yeah, there we are. So when I did surgery for him at that time, this was a while ago, he had a big gaping hole in the conjunctiva. Big gaping hole, and you can see the BCL. I put BCL and I gave him doxycycline, but as you can see here, it was frankly leaking. He did get better, but it was a very traumatic time for him. because this was his better eye, his other eye being much worse. Oh dear. Can I just stop share for a minute? So you can see the leak, the really frank leak, and he was a nightmare to manage. But anyway, after having talked about what you need to be aware before you take up angle surgery, what you should also be aware, what you should be avoiding. And in topmost on my list are synechial angle closure. Now, secondary open angle glaucomas like pseudoexfoliation syndrome, pigment dispersion syndrome, these are all indications for surgery, but secondary synechial angle closures are not. PACG is not. If the angle does not open up after PI, then I think one should refrain from doing it. Small goniosynechy, it should be fine, but a pass more than 1 to 2 clock hour, one should avoid. And of course, neovascular glaucoma, uveitic glaucoma, other secondary refractory glaucomas, and of course, advanced glaucomas are a no. So I'll quickly share this before I stop. This 61-year-old, this is actually the first iStent done in this country. He had mild POAG, but because his pressure was not controlled, he had undergone TRAB and a needling elsewhere, and I had to do another needling, and it did not work. And in the 5 years after surgery, he was on 5 drugs to control his pressure. He also subsequently developed severe intolerance to anti-glaucoma medication. His IOP was 22 in the right eye on 5 drugs and 29 in the left eye on 3 drugs. And he was, as you can see there, mild glaucoma. So this is how he looked prior to any intervention, only on anti-glaucoma medication. You can see the papillae and the redness, and he was talking about irritation all the time. You can also see the bleb. You can see the bleb that he has on the right side, no bleb on the left side. This is after I stopped the most of the medications and put him on Diamox. So he underwent a phaco iStent in September 2021 in the right eye and a phaco iStent in the left eye in January 2022. And if you've done an iStent, you now know that this is a standard that the Glaucos company does. So what happened when post-phaco iStent, you can see how beautifully white his eyes have become. And just as a reminder, you can see pre-phaco iStent, this is how he looked. Oh, sorry, I needed to put another slide there where now I have more than 18-month follow-up for his right eye and almost an 18-month follow-up in his, not almost an 18-month, sorry, a year follow-up in his left eye. His pressure in the right eye is 17 on 2 drugs. This after being on 5 drugs and being uncomfortable, he's very happy with. And on the left side, now he's on 0 drugs and his pressure is 18. And that is an absolutely fine target IOP for him. So TMB is indicated in mild to moderate disease, determined predominantly by the Anderson criterion or the HPA criterion. It fills the void between medical management and more invasive traditional surgeries. It appears to be very promising when there is AGM intolerance, ocular surface disease, side effects in mild to moderate glaucomas. And in its current form, it is not competing with TRAB. TRAB is still the procedure that you need to do in advanced glaucomas. You need not do these procedures in mild to moderate. It spares the conjunctiva. These procedures spare the conjunctiva, so you can still do a TRAB later. And it's easily combined with cataract surgery and can be used standalone too. It's very useful when compliance and adherence is poor. Please remember, it is very patient-centric. Why? How? There are safer, much lesser number of postoperative visits and early visual rehabilitation, and the reduction in the anti-glaucoma medication has several advantages. It eliminates issues of non-compliance, non-adherence, decreases the recurring cost of anti-glaucoma medication, and of course improves quality of life. The eyes are not red, teary, watery anymore, and they're not complaining every time they're coming to you that their eyes are uncomfortable. So I would offer MIGS to all glaucoma patients who are undergoing cataract surgery. Of course, they have to be mild to moderate, especially when there is AGM intolerance. And of course, cost may be a limiting factor. So I end with an answer to this question, why to intervene early? I firmly believe that we need to reset the anti-glaucoma medication clock for a patient. What does that mean? If the patient is on 4 drugs, I eliminate it completely or reduce it to 1, maximum 2, 1 bottle. It improves quality of life for the patient. It has an excellent safety profile. And in controlled glaucoma, also you see an additional IOP reduction with, of course, reduction in anti-glaucoma medication. And there is a very low reoperation rate. So failure is not that high. Thank you very much for a patient listening. Yeah. I think, Sushma, you go ahead with your presentation.
Start?
Yes.
Okay. So, well, thanks, Saikat and Glocos, for this opportunity and the introduction. I'll just I'm just going to basically share some videos and the initial experiences and the techniques that you need to learn before you start iStent Inject. Initial few slides I may skip because Dr. Vanita has taken care of that. So, sorry?
Go ahead, Sushma.
Okay, sorry. So I will just go through the challenging cases at the end and how do I manage them. So to begin with, well, now we know that trabecular bypass microstent is the smallest stent that we are using. And in India, it started in 2021, and most of us have started using it at that time or in 2022. Well, these are the different generations that Dr. Vanita has gone through, and we have the newer one, iStent Inject W, which has a wider base, so the over implantation is prevented. I'm just rushing through that. Now, what is the preparation that is required for an iStent Inject? These are certain key points, and I'll just touch upon each one by one. Well, we need to understand the features of iStent. So basically, since we have talked about dimensions and the outlets, just to understand that this is the conical part that pierces the Schlemm's canal wall, and this neck sits into the wall of the Schlemm, and this one is exposed in the anterior chamber. So that's how the flow goes through. And the differences that are largely there is a wider flange in iStent W, so that the chances of over implantations are less. And also it is easier to see as compared to iStent Inject. Well, this is the injector system. Since we implant the iStent through that, we need to understand it very well. So this is a sleeve retraction button, the green one. So you have to pull it back to be able to retract the sleeve. The black one is a stent delivery button. So when you're ready to inject the stent is when you are going to press it. And mind it, there are only 4 clicks which are there for the 2 stents. So you have to be careful. If you unnecessarily press it, you will lose the clicks and then you will not be able to implant. There is a microincision sleeve which covers the trocar and the stents threaded into it. So if you look at the trocar, this is how it looks like. There are 2 stents, and there is a microinsertion tube, and there is collet in which the stents are lying, and there's a push tube that tends to push when you have the click. Now, the difference in the W injector system is that there is a shorter window with a bridge between the 2 stents so that you can see them better, and also the chances of trocar bias are less. The tip of the trocar is also better in W injector system so that there is less tethering of the tissue. Now, there is certain amount of learning curve when we start with iStent surgeries, because we have to operate under very high magnification and we have to operate in a relatively extended elbow position. I will show you why. You have to work at the angle. So there is rotation of the microscope and the patient's head position that all of you must be knowing. And more or less, if you're using a gonioscope, which most of us use, is a handheld gonioscope. So one hand is used for holding the gonioscope and you have one hand available to do your work on your injecting system. So we need to look at our working position. This is how we usually operate when we do cataract surgery. But when you have to change your microscope position and the head tilt of the patient, your elbows are actually extended like this. You can optimize a bit by changing the position of your eyepiece and all. The maximum you can do is still different than what you would do in a regular position. If you can look at the angle that my elbow is forming here, you'll understand that this is how we need to learn to work when we are going towards the iStent. The anatomy of the angle, all of us are aware. What I want to highlight here is that you're working with a Schlemm's canal, which has a wall of less than 200 microns, particularly in primary open angle glaucoma patients. So meridional diameter itself is less than 200 microns, and TM thickness itself is less than 100 microns. So when you're working at such a small tissue, where you have to inject this implant, you actually need to work under very, very high magnification. So routine magnification that we use in the microscope is 4 to 8x, whereas in iStent we use 15 to 18x, sometimes even more. So you need to be sure that your view is very stable and your movements are limited, because the little movements can get magnified and can disturb your surgery or view. You need to understand that you have to manage yourself with one hand, because the other hand is holding the lens, unless you have an assistant to hold, which I usually do not prefer, because the coordination is better when you're holding the lens or gonio lens yourself. Sometimes you may require assistant's help to stabilize the eye in the initial cases, if you are getting the loss of view while operating. And also you need to take care that there's not significant egress of viscoelastic when you're putting your instruments in, or the surface bleeding. To avoid that, you should have corneal incisions, so you don't have blood coming between the prism and the cornea, so that can obliterate your view when you're working on the angle. To optimize visualization, before you actually start working on angle surgeries, you can practice that in your routine cataract patients. At the end of the surgery, you can use a gonio prism, change the position of the microscope and the patient's head, and see how you can best visualize the angle. So practicing that, or taking a iris depositor or blunt instrument to touch the angle, will give an idea of which position you're going to work in and how your hand maneuverability would be there before you actually take up a patient for a angle surgery, or particularly the iStent. So practice helps, and preparation helps. Well, now to just, it's a short video of the routine iStent inject procedure. It has a voice over, so I will not speak for next 2 minutes, and you can see this video. The iStent inject procedure. Any of these intraoperative gonio lenses can be used to perform the procedure. This prism is an intraoperative gonio lens with a wider field of view. The concave surface rests on the cornea and the flat surface is towards the surgeon to see the angle. This is the eye prism SX that has a self-retaining surface, so that minimal support is required for holding. The iStent injector looks like a pen with a long tip. It has a blue button to retract the sleeve and a black button to implant the device in the Schlemm's canal. Here, under high magnification, we can see the tip of the trocar that is exposed after retracting the sleeve. The stents are seen in the injector. Now we shall demonstrate the surgery for a 65-year-old patient of primary open angle glaucoma and cataract on medication. The plan was to do a phacoemulsification and iStent inject. Initial surgical steps and technique is similar to that of phacoemulsification. Here it is being done with phacochop, and the patient is being implanted with a toric IOL in the back. After that, intracameral pilocarpine is injected, and then AC is filled with Helon GV. Before moving forward to the next step, alignment of the patient's head and microscope should be done. Surgeon should be sitting temporally, and the patient's head is tilted 35 to 40 degrees away from the surgeon. Microscope is then tilted 35 to 40 degrees towards the surgeon, so that the surgeon's eye, microscope, and angle of the patient's eye is in one line for easy visibility. You can mark on the microscope for the required tilt and align the marks while rotating. After changing the position as described earlier, the gonio lens is placed over cornea to visualize the angle structure. The injector is then inserted through the main incision. The sleeve is retracted as one reaches close to the angle. The tip of the injector is then used to tent the area of trabecular meshwork with trocar, and then the device is injected by pushing the black button. The trocar and the injector is then withdrawn, keeping the black button pressed. The second stent is placed 2 to 3 clock hours away from the first one in the nasal angle. After implanting iStent, it can be nudged with trocar to ensure it is well implanted. It is very common to encounter bleeding while implanting the iStent, which can be washed using irrigation and aspiration while removing viscoelastic, and wounds are hydrated to close the eye. On first post-operative day, one may note a small bleed around the stent area. On first post-op week, patient had 6-6 vision and an IOP of 14 millimeters of mercury. And this is the angle of the patient demonstrating iStent in place on gonioscopy. Okay, so this is the standard procedure that we do, and this is the iStent W procedure. I mean, the procedure is more or less similar. Just to show you, the injector is little different. You have a bridge there that prevents the actually trocar bias. I feel better. This injector is much better than the iStent injector. So the same way, you can put a gonioscope and look at the end pass view of the angle by changing the position, and here the first stent is being injected. So you give a little indentation and the stent is there in place. Then you move 2 to 3 clock hours away and do the second iStent Inject W implantation. So this is the procedure is more or less pretty simple, and I feel it is more controlled with the iStent Inject W. So the trocar bias is also very less, and you can actually visualize if there is a trocar bias. So the viscoelastic is being washed away with the irrigation aspiration, and here you can actually see the the blanching of the area also. This was done on a microscope which has the intraop OCT, so you can see the elevation of the conjunctiva as well. So this is the area of blanching, as you saw. The post-op, on the second post-op day when I did the gonio, there was one stent and the other stent had a bleed over that. However, that disappeared in a week's time. You can still see the iStent under that streak of blood. And then after a week, that the blood disappeared on its own. So this is the post-op view of the same patient. So there are certain situations which can happen in intraoperatively, which I'll be going through one by one. There can be bleeding from the angle. There can be shifting of focus due to movement of the gonio lens. There can be shallowing of the anterior chamber. There can be bleeding on the surface that can obscure the view. There can be under implantation or over implantation of the iStent. There can be wrong implantation of the iStent at a place where you do not want it to be implanted. So let's see how we go about it. To ensure that you get an en-face view of the angle, what you need to do is that, as I had described in the first video, you ensure the tilt and then start focusing. Sometimes even after that, like in this patient, I'm not still able to see the angle very well. So while your prism is on and you're in that position, you can still do the further tilting based on a particular situation. So here I'm moving the patient's head further away from the surgeon with the lens being in place. However, I'm still not happy with the view. So I'm tilting the microscope further towards me. So those adjustments can be done. And then again, you can make an attempt to focus on the angle. So unless you're comfortable on visualizing the angle, we should not be proceeding. Here I start with the injector system. And as I go close to the angle, I was still not comfortable. So if you can notice, I have touched the trocar there, but still not injected because I was seeing folds in the angle. So I did not inject the stent. And if you see, the folds were pretty common. And I was worried that if there is more hypotony, then I'll have more bleed. So you can zoom down, go through your port, inject more viscoelastic, so that the eyeball is tight and there's no longer those corneal folds, and then zoom up again once you have inserted the viscoelastic. Once your view is clear, then only you should So this is the example of a clear and fast view, and this is the poor view. So once you're sure about the view, then only you should start the placement of the iStent. Well, I was talking about the trocar thing. So the newer injector trocar bias thing. So to avoid the bias, you should make sure that the trocar is seen through the central tube. Now here in the new injector, you have 3 windows through which you can see the trocar. So if it is biased, you will see through one of the side tubes. But you should inject only when you are seeing through the central tube so that there is no trocar bias. Well, bleeding in the angle is also something which can happen. Sometimes you have a significant amount of regurg, so much so that, for example, in this patient, as I went ahead and injected the first iStent, the moment I pushed the iStent there and I retracted, I could not see anything but the blood. Now, in this situation, you should not get jittery and try to remove the blood. Go to the 2 clock hours away and inject the second iStent, which is there in the injector, so that the implantation is complete. You can examine the injector system to see whether there are any stents left behind. And however, since both the stents were covered with blood and I could not see very clearly, so again, you can go inside and use the viscoelastic to displace the blood. And you can see both the eye stents were in position. However, because of the immediate regurg, they were covered with blood. So most of the time, you can get away with the small manipulations and displacing the blood away with the viscoelastic. If in worst case scenario, you may have to come out, irrigate the whole thing and put back the viscoelastic and see. So these are very small things that we have to take care during the surgery. Another thing that can happen is the improper positioning of the iStent. So sometimes when we are not very clear where the angle is or the blood comes across, there can be this problem. Like in this patient, when I injected the first stent, that was quite well in position. You can see it's gone onto the trabecular meshwork very clearly. Yes. And when I go to the second position, while I'm injecting, if you can notice, there was an air bubble that was right here, and there's an air bubble which is coming very close to the tip. So that made my visibility very compromised. And I did the mistake of injecting it there and then. And you can see the second iStent I have actually implanted on the scleral spur. It is much beyond. So this is the correct position, that is on the trabecular meshwork. And this one is in the incorrect position. It is at the scleral spur. So obviously this is not going to work. So there's no point leaving it here because that is going to be useless. So you can take a micro forceps. You can hold the iStent and it comes out easily. You can put it on the sponge I used for this thing so that it does not slip through because it is very small. So under high mag, you can re-thread the implant into the injector because as I told you, there are 4 clicks. So I have used only 1 or 2. So third one is what I can use. So the same injector I can use and re-implant the second stent in the correct position. So this you can see it's going little out of view, but I could implant the second iStent also onto the trabecular meshwork. I'll show you in a bit. Yeah. So this is where the second implantation is done. So now when I'm clearing the area with the viscoelastic, you can see that this is back in the correct position. So it's very simple to pick it up. You can even pick it up if it is under implanted. You can even pick it up in the anterior chamber itself and rethread onto the injector system there and then. This is another stent I had where I injected the stent, but it did not go through that. It is one of the initial cases where I think I had a trocar bias. This is iStent inject, not the W. And the iStent came along with the trocar and was lying there in the anterior chamber. So here again, you can simply pick it up with the microforceps, place it at on a sponge or a rough surface and rethread it and re-inject it. So that's pretty simple. Go back to the same position, clear the blood and go back and inject it. So again, this is the importance of looking at the trocar bias so that you don't go at wrong place. There can be certain post-operative challenges. Sometimes a small blood clot can come near the stent in the early post-operative phase, but most of the time, or almost 100% of the time, it disappears on its own. You really don't have to do anything. But the advantage of iStent is that you don't get largely a bigger bleed or anything. It is just a small blood in the angle or close to the iStent that you get, and that usually resolves on its own. You really don't have to do much. The second thing that can happen, and is it happened very recently to me, that you can have synechia formation near the eye stent. So this is a young patient who have operated steroid-induced glaucoma and cataract. So this eye stent is okay, but the second one is being covered by the goniosynechia. So I started this patient on pilocarpine. However, that she did not respond to that. Today only I saw her after pilocarpine 1 week. So we definitely, I mean, I'm planning to take her up to remove that goniosynechia from there. What you need to keep in mind is when we are trying to remove the synechia, it is a possibility that the eye stent may come out. So you have to be ready with the injector, with the residual clicks, so that you can rethread it and put it in case the implant jets out of the Schlenz canal while you are removing the synechia. There can be certain instances of high IOP in the early phase if there is residual visco or steroid response. There can be some amount of inflammation, which I have not yet seen in any of the patients though, but can happen. And I think as Dr. Vanita clearly pointed out, the hypotony is very, very rare. The possibility in eye stent and significant amount of bleeding also is very rare in eye stent situation. So those are certain post-operative challenges that we need to take care. Well, as far as the outcomes are concerned, there is this published data of large series of 340 eye stents, and they have shown a significant reduction in the IOP as much as 16%, and mean number of reduction of medication was 67%. Interestingly, the number of cases out of 340 that required secondary surgery is very minimal. That is 7 eyes required SLT and 8 required filtration surgery, which is a very encouraging thing. Coming to my outcome so far, well, I have a small number. So the maximum follow-up I have is 14 months and minimum is just 1 week. The last case that I showed you that had goniosynechia. Most of my patients, all of my patients were primary open angle glaucoma. Most of my patients were in 1 or 2 drugs. Only one patient, if you can see, was on 4 drugs. But so I was expecting that within a couple of weeks, I will have to start him on medication. But as far as now 1 month is over, but I'm yet to start him on any medication and the pressures are 11. And none of the patients right now that I have done iStents are on any medications for now. Although it is too early to say, and I may need to do that in follow-up. I may be able to share my experiences next year in a better way. Well, having said that, iStent has been a very popular surgery and is already in controversy. Cataract surgeons want to do it, glaucoma surgeons want to do it, and that's well and good. But the most important message that I would want to give is that it should be done for the appropriate indications so that you can get the optimum outcomes. Thank you for your kind attention. You're welcome to ask questions and comments.
Thank you. I think thanks. It was very intense, and of course, this may be the first situation, first of its type session where we have talked about the problems of implantation rather than with only the good, all are successful things type of situations. I think I'll open it up for, I think I heard some comments from Dr. Alka, excellent presentation. Yeah, if we can open up yourself to ask some questions, any queries. I think there was a query with Dr. Anu was asking, when can we expect to see the IOP lowering? Dr. Vanita responded almost immediately. And I think
yes,
this is one part which is very important, that how to stop the medications. And I see that there's a lot of confusions still now across the country, mainly after iStent Inject, I can vouch for. I think if you can just share your comments also, Dr. Sushma, how do you, Dr. Vanita said, of course, she stops it immediately and then start reintroducing. How is your protocol?
Same. I would not start anti-glaucoma medications post-operatively. I mean, as I showed you, my outcomes till now, I have not started in any of the patient. I did not, thankfully, had to restart any glaucoma medication in any of the patients, because maybe most of my glaucoma patients are mild and moderate, except for one which was on 4 medication. But also the severity of glaucoma is not too much. So there is no point starting anti-glaucoma medication on the day one, because you would not know the outcome. iStent does not take time to reduce the pressure. It is immediate as soon as you put the iStent in. So unless you stop the medication and see, you will not understand what is the outcome that you're getting.
This is exactly what I said, that you don't know how much your device or procedure is working if you have not stopped the medication. Your medication may be working, and then you will become reluctant to stop the medication. This is what I see with the majority of surgeons. And in fact, at the expert panel meeting in Bangalore, we couldn't get a consensus on this. There was a 50-50 split on who actually discontinues and who continue medication post-operatively. I would like to answer that next question by Ramya Shri, and I would like Ramya to switch on her video and audio and give me the exact situation, what she means by trap failure. Ramya Shri, are you there?
Yeah. Hi, Dr. Vanita and Dr.
Hi.
Sushma. Thank you so much for this excellent presentation. So I have a patient who is moderate glaucoma by HVF criteria, but has undergone a TRAB long ago, somewhere about 2 to 3 years ago, and he's on 3 medications, and he's allergic to most of the medications that he's using. So I was contemplating to do an iStent in him as a standalone procedure. I was not sure. Uh, he's yet to come back. So I don't know. There is a flat bleb, and the AC is not very deep. It is slightly shallow, but I can see the PTM.
Is this your first attempt at iStent?
Yeah,
I wouldn't do it.
Yes.
I
even
shouldn't be.
Do you agree, Sushma? It's
Yes, I
not.
agree. No, not at all.
You do not go to complex situations and start a new, and shall I add this, Saikat, an expensive device. You
There is
are
no
not sure, you are unsure what your response is going to be. It isn't a situation where most people would do iStent. So, that really wouldn't be my indication for iStent. I've never done angle surgeries alone post failure of trabeculectomy. I may have done ECP, which is not an angle surgery at all, but not an iStent or KDB.
I have done angle surgeries, but not the iStent, of course, for post-trap failure, juvenile glaucoma and all, but not the iStent still in a post-trap failure.
And if you're, excuse me,
Yeah.
your aim is to eliminate all medication, then there is a huge issue there. Anything you do now with the failed trap and with so much intolerance, or I don't know whether there's allergy also, it becomes very difficult, the choice of what surgery you could do in this patient. But I certainly would not do an iStent. I mean, I could try a GAT or a KDB. No, not GAT. Sorry, Bang or a KDB.
Yeah,
Bang.
KDB or Bang is what I would do.
I could try that.
Yeah. And I would do it in a wider area rather than just a smaller area, KDB or Bang, so as to open up the.
But of course, I have the ECP. So for me, my choice is in a pseudophakic eye, there is no issue at all. Yeah.
One question is also, is Pilo required post-op? I do not use Pilo post iStent. I don't know about Dr. Vanita. What would you say?
I don't routinely give Pilo, not in iStent anyway.
Yeah.
Maybe when you're doing, and this is a point I actually learned from Alka at the Prayogshala. She says we're giving, I mean, Pilo is pro-inflammatory, but we are giving anti-inflammatory drugs to the patient. So perhaps maybe in sort of the goniectomy type of procedures, yes, maybe, but definitely not in iStent. I have not felt the need at all.
Yeah.
Just do not dilate the pupil. Let the pupil be its normal physiological self.
There are more
Do you say?
questions.
Yeah, I think Dr. Alka.
Yeah, Alka also responded saying if post-trap failure is pseudophakic with wide open angle, but she said it's not wide open.
Yeah.
Of course, we can try, but my point is you have to have a few procedures under your belt, a few procedures in normal type of cases, not complicated cases. After that, what you do is really, your judgment. I don't think we can dictate on that, but definitely I would say that when you start, it should be the non-complicated open angles.
Yeah. About the standalone thing, I wanted to say that I have done a couple of standalone cases, but those are like pseudofakes or purely wide open angles. So there it works pretty fine. Although I know it's not what do you call approved for standalone procedures. But again, it is your judgment if the angle is wide open and your indications fit in like mild and moderate glaucoma. So I think that should not make any difference. Doing it standalone.
Also, I think Zia says she would try bleb needling. Now, when someone says failed trab, I presume that someone has also tried bleb needling. We look at bleb needling as a separate procedure, but actually it's very much trab management. So yes, if bleb needling has not been tried, that can be tried. However, if the surgery is not yours, then it's and if it's needling is not something you do on a regular basis, then of course that is also fraught with failure. But yeah, that is very much a procedure that can be tried. Is iStent indicated in NTG patients? A good one. What do you think?
I would not do. I would not want to do iStent in an NTG situation because I don't expect pressures to go so low, which I would want in an NTG patient. So for me, it's a no-no.
So yes, doing it is not the issue. You will not get low enough pressures. Is the situation. So I agree with you. I mean, if I am not getting the desirable target IOP with the two medications that I would bank upon very heavily in NTG is prostaglandin analog and a carbonic anhydrase inhibitor. And these two are not working. Really adding on anything else is not in my, unless the patient is reluctant, of course. So then trabeculectomy may be the answer. I don't know. Angle recession and iStent is a good one. I have not done so far, but I have done angle surgery in angle recession. It's worked very well. Have you done an angle recession, Sushma?
No.
Huh?
But,
No.
but
So
in
like
angle recession, there is scarring. There is scarring
That's
of the
correct.
trabecular meshwork. So,
No, it's
but
not
will the
so
iStent work is a
uh,
question.
That's what. But you see, one is also worried about pigment, but if it works in pigment dispersion and pseudo exfoliation, there really should not be that much of an issue. However, when they talk about pigment dispersion and pseudo exfoliation in Caucasian eyes, believe me, it does not look half as bad as it looks in our kind of South Asian eyes. So I feel there is definitely more pigment and which is more prone to inflammation in darker irides. So actually, if you ask me, I have not done in pigment dispersion nor in pseudo exfoliation so far, in spite of having done a few. in the past year and a half, maybe more.
Good evening, ma'am. Very nice presentations. Just wanted to know, like, if these iStent patients post-surgery, anytime in the future, if they require any other intervention, would it have a risk of dislodgement if any VR procedure or any other procedure for it?
The company says once it's in the correct position, it does not get dislodged. In VR surgery, why would you come anterior? You're not in the anterior segment at all.
Any other procedure for that matter, if
What
at all it is
procedure?
complicated.
Cataract?
No, cataract is already done.
Okay, cataract is done. So what procedure would you like to do? Corneal?
Yeah, corneal or any other procedure.
No, you're nowhere near the angle. Why should it even?
PK.
Yeah.
PK.
Yeah, even PK. Even PK. You know, nowhere near the angle. Your button, corneal button at the most is, for a large graft is 8 millimeters.
Mhm.
Is not so wide. Your angle is maybe
13
13
millimeters.
millimeters.
Yeah.
Yeah.
So the only thing which can dislodge is when you're doing angle surgery yourself by doing excision goniotomy or something in a patient where the iStent has failed, and you would know where you have placed the iStent, so you will be careful. Nobody else will touch the angle, whether it is retina or cornea or any other, because it's a nasal angle.
I don't see it. See it being dislodged unless it's under-implanted.
Yeah.
And
Or
you
you're
have left it
actually
like that.
opening the angle with a, say, KDB and all over that, because you're going to disrupt the anterior wall. So that you yourself are going to do, and means angle surgery. If you're doing, then you would know that there are iStents there. So you're not going to disturb that.
True. Anything else?
So I have a question about to Dr. Vanita about choosing the right patient.
Yeah.
So if you have a patient who had occludable angles and you've done a PI, but the angle has not opened, but there's no synechia.
Has
I
not
would
opened,
not.
but on indentation you can see.
It is, yeah, on indentation there are no synechia, but there is still persistent apposition.
No problem. You take the lens out and you do the.
Yeah, so that's what I would have assumed, but only if the lens is contributing to that persistent apposition. When you remove the lens, you will have an open angle.
That is a
But
judgment.
if it's actually a plateau iris with ciliary body, even post-cataract extraction, they still have persistent apposition, which will be artificially open temporarily during your cataract surgery. So do you split this procedure, as in do the cataract, then assess the angle with the cataract removed and then plan it? Or do you do an ASOCT and look at the lens vault? Or what the...
See, for me, actually, it's pretty simple. If I have plateau iris syndrome and if that patient needs a glaucoma procedure, I will do endocyclophotocoagulation. And that completely corrects the plateau configuration, at least for 180 degrees. And so the patient actually does very well. Now, if you're thinking about angle surgery, then you have to see whether, how many drugs the patient is on. Is the disc actually affected at all or not? If the patient is on 1 or 2 drugs and probably removal of the lens itself alone might work, then in that situation, I wouldn't actually combine it with an iStent. I would just take the lens out and not worry about the anti-glaucoma medication, because I feel that might go down. Especially in the scenario where there are so many PAC cases where the angle it's still appositional, and you take the lens out and it opens up quite well. And if you require it later on, maybe you can do it as a standalone procedure. You need not combine it with cataract. Yeah, Sushma.
Makes sense. Thanks.
If I may add to it, if I am doing a angle procedure in an angle of closure where I've done a PI and then I'm looking at, so I think we definitely would keep in mind plateau iris configuration on gonioscopy, and we can even rule out on UBM so that there is no plateau iris configuration if we are heading towards an angle surgery in a situation like this. So that definitely is a ruling out thing for me if I am proceeding with any angle surgery for that matter in a situation like this. So as to
That's what I'm
understand
saying.
whether the lens is
Better
responsible.
take the lens out and see what the residual angle looks like, and then maybe consider later.
Yeah.
Although I feel that, the advantage of a MIGS is lost when you're not combining it with cataract surgery.
Yeah.
I'm a great proponent of doing it with cataract surgery rather than staging it. If the patient is only on 1-2 drugs, then they may as well just continue after cataract surgery if they are not keen on MIGS. It does not make that much sense to me, and so that is how I motivate my patients also, that
Sure.
if the time to do it is with cataract surgery, otherwise you continue, and then later on we will see how what needs.
So yeah.
Okay. I think it's a very interesting, but only thing, the clock is ticking and 10:10 is the time, I think, for all of you. I know it's very interesting. So if you have any questions quickly, you can go through. Otherwise,
I think we've answered all the questions that are there on the chat box.
Yeah.
So someone has done a needling elsewhere for that patient.
That's
Trab
patient,
failure.
yeah.
So that's what I'm saying, that when someone tells me that trab has failed me, I assume that there has been a needling and that has failed too. Yeah. So,
Good.
yeah.
I think I would really like to thank Dr. Sushma and Dr. Vanita to really take your time out to create this presentation. This is not a very, run-of-the-mill presentation, which you may have been doing in many of the platforms, but you have really created those videos and critical situations, and this will surely be helpful for the people who are trying to start with it or has been doing it. Thanks to both of you, and thanks for the audience to really and put in so much of questions. We will try to continue with this type of interactive and inform content or situations in the next for the couple of months or in the next year of all throughout the whole year as a regular. Okay, I think Dr. Suchanda sir has some comments. So thank you, thanks a lot.
Just can I just put in a question, Vanita?
Comments. Yeah.
Sushma, both were excellent teaching presentations. Shweta, you made a comment that the
Sushma.
iStent, Sushma, you made a comment that the iStent dislocated. You went in with the injector with residual clicks and re-threaded it and took it out on another session. So do you?
No, not another session. That was the same session. The iStent was in scleral spur. I immediately took it out. So the same injector, because it has 2 extra clicks.
Okay. Oh, it's never been that you have found one lying in the AC later on. No.
Yeah, no. It has never been like that. But anyway, I still preserve those injectors in case I have to use it later. Say, for example, the situation I showed you, there's a goniosynechia there. If I'm going to dislodge it and the iStent comes out, then I will use those injectors which I would have ETO'd and left with the residual clicks to inject, so that I don't have to buy another one. So Saikat would be unhappy with this, but
No. I think this is Dr. Suchanda. I would have to say this. This is Dr. Sushma et al. Concept, which we have been now started using it. We have also started telling it to people. It is about when you are doing the surgery. If you have done it with 2 clicks, we normally throw away the injectors or we using it for training. So what Dr. Sushma suggested us, that why don't we preserve it, ETO it, and keep it within in our OT, at least 2 or 3 of them. Now, if by chance, even during the surgery, if you exhaust the 4 clicks and still you have 1 implant left, you can use that injector. Or in adverse situations like this, where you are trying to take it out in a post-operative situation, you take it out, re-implant it, then you can use this injector. So this is a very unique thing which she has suggested, actually, which you have heard it rightly.
Yeah, it's a great idea. Vanita, you talked of an over implant. How can you make out in the OT that you are over implanting? Is it clinically?
If you are on high magnification, you will see that the base of the inject W now is not as clear and with a sheen and shining. It seems buried. If you have already done one, if you compare with that one, that is a little proud of the surface of the trabecular meshwork, just a little. Whereas this one seems buried.
Okay.
Okay.
Thank
Yeah.
you. Thank you.
Actually, over implants also can be extracted. There'll be a little bleeding. You have to be careful about that. You clear the bleeding with your viscoelastic, good quality, high density, high molecular weight viscoelastic, and you wait for a little while, let it settle, and you can use another site to reimplant. All these things we have done. It works. It's not, yeah, it doesn't work. And yes, those extra clicks help, but there is always that clock ticking at the back of your head saying, okay, we are now 3 down. You only have 1 more click. So it's a little bit of a pressure situation, but it can be managed. It's not an issue. Yeah.
I think once we have the infinite, we'll get away with that idea, because that has infinite clicks.
Yeah. And three in one, yeah, 3 injects.
That's the same thing. That infinite and 3 clicks, 3 implants, but the number of clicks is infinite. So it's a manual actually.
Yeah. So I'm sure that takes away from the nervousness and the anxiety on table.
Yeah, maybe. Yeah.
Okay.
Good.
Okay.
I think it's time to close now, Saikat.
I know that's what I was about, but I think you have created enough interest and a lot of queries are there. Thanks to both of you. I think we will just close it. No other things to do, but thanks. We will come back to you about the inputs, and we have actually have the session recorded. Let's see how we can, if anybody wants to use it or if you want to go through it, we will come back to you on this for that. Thank you. Good night.
Okay.
Thank you, everyone.
Bye.
Good night.
Bye.
Thank you very much. Thank you very much. Thanks a lot.
Bye.
Bye.
Thank you, Doctor. Bye.
We are really running out of time.
Yeah, I'll do that.
And then we can take questions if there are any.
There are one or two in the chat. We will take it later.
Yeah, can you see
I'll
the
see if I
slide?
can answer them. Yeah.
Yeah.